So what is your strategy for biomarker testing in metastatic hormone receptor positive metastatic disease?
So I think, right now up front, to confirm recurrence, I'm usually, that's the time I'm getting a tissue biopsy. And nowadays I've across the board shifted to sequencing blood and tissue up front on that specimen, just so I understand the existing mutations. And I think at progression, looking at doing ctDNA at that point in time, primarily to help figure out, are we seeing an emerging ESR1 mutation? Has there been any other acquired mutation that we didn't see before? But that's the main one that I'm looking for. That might be new. And then kind of looking back to see, was there an ERB2 alteration? Making sure we've been thorough to make sure we know about PTEN and AKT alterations. And then I also do, for all of our metastatic patients, dedicated germline. Making sure we address our PALB2s, BRCA1, BRCA2s that are there to try to figure out what to do second
if they
line.
weren't tested early on.
If they weren't tested,
just confirming. I really think that is important. I agree with you. I mean, I think most of us, it is the standard of care now to biopsy confirm metastatic disease. I also agree with you on doing both tissue and liquid because you do see discrepancies and you find things you weren't expecting. I also think...
Did you do that off the bat right away, or with Inavo 120, did that influence kind of selectively who you might do tissue and blood, or have you always been doing blood and tissue concurrently? I'm just curious how other people tend to practice.
I have leaned, tissue, I think, because that is the time when you get a fresh biopsy. So that's really the time you're going to have tissue often in these patients. So I've routinely been doing that, but I have added blood in because just of a few discrepancies. Many of the blood-based tests do look at germline findings. So you kind of are getting that double check on germline. And I think the other thing I'm looking for on that tissue-based testing is I have a few, very high TMB patients. I've caught some somatic, BRCA mutations, right? So there are some things you can catch that really might change what you do even in the first line.
I think, look, we did a little bit of work to look to see, can we take the ctDNA findings on germline as ground truth? And then the concern there is that most of the dedicated germline sequencing, they do orthogonal testing to capture those large gene rearrangements, which admittedly are only 10%.
Right, but you still might miss some.
And we saw that when we did it. And so I tend to
just do it, just dedicated.
Do it. Let's get the test.
If they haven't had it in the last 5 years or so, it's one of those check boxes. Have they had that done?
Exactly.
I'm with you. I think that's a really reasonable strategy.